On behalf of IPCA, I welcome you all on the Expert Outlook web series. And this month, as you all know, is a month of hypertension, and we are celebrating Hypertension Month across world. And on 17th, already we are celebrating Hypertension Day. It is to understand the prevalence of the hypertension, which is a silent killer, and which is a very serious disease, need to take very seriously in terms of understanding and the treatment and the updation. So on this day, we have very eminent speakers who will be guiding us on different aspects of hypertension management. We'll be having three speakers, and I want to introduce them one by one. First is Dr. D.K. Chauhan, who is a MD, who has a PG diploma in diabetes, and is a consultant physician and chest specialist practicing in New Delhi. He will be speaking on the role of beta blockers in the management of hypertension today. After that, that will be followed by the Dr. Sanjay Gupta talk on common mistakes in the management of hypertension. Dr. Sanjay is a MD medicine and a DND in deploying diabetology from Australia. He is a senior consultant physician and diabetologist, and he's practicing at SD Diabetes Center in Kamala Nagar, New Delhi. After that, last but not least, we'll be having one eminent endocrinologist, Dr. Saket Khan, who is a MD medicine and DM endocrinology, who is a fellow of American College of Endocrinology and a consultant endocrinology practicing in Delhi. He'll be speaking on diagnosis and management of hypertension in young. So after three talks, we'll be having question and answer session where all the audience which are logged in can have their questions, and that will be answered by the panelists. So with this, I'll hand over the session and invite Dr. D.K. Chauhan to start his presentation. Sir.
Thank you very much, Nipunji, for a kind introduction. And I'll start with the session itself. Well, today's talk is on role of beta blockers in the management of hypertension as of today. Well, we'll be talking about historic aspects, indications, controversies, type of beta adrenergic receptors, heart failure in our country, important trials, guidelines, and then the summary of the presentation. It's going to be an hour's talk between the three of us. So I think I've been allotted 20 minutes, and I'll try to justify those 20 minutes with all these slides. If you look at the initial journey of beta blockers, it started in 1900. Yes, I'm talking around 1.25 century back. Ehrlich and Langley proposed the receptor theory first, and it held till today. And if you trace the journey, the historical aspect in 48, Elquist finds alpha and beta adrenoceptor subtypes, and then 58, the pharmacological properties have been found, etc., till today. And if you look at it, beta blockers were first developed by Sir James Black at the Imperial Chemical Industry in the United Kingdoms. He published his first work on beta blockers in the year 58, and 30 years later, Sir James Black was awarded the Nobel Prize in Medicine 1988 for advances in medicine. So it has been found and established by no less a person than a Nobel laureate. What are the actions of beta blockers? Beta blockers, they block the chain of action of endogenous catecholamine ephrines, adrenaline and noradrenaline, on the beta adrenergic receptors, as the name suggests. The sympathetic nervous system mediates the basic fight or flight response of our body, and all the animal kingdom is endowed with these fight and flight mechanisms. And this has evolved over millions of years. Prolonged excess activity causes disease, and beta blockers are used to treat these disease. To give you a simple example, if somebody is to live with a pistol on his head in that mode of fight or flight, how long? Either you fight or flight, but you can't go on living like that. So this is a sort of theory. Prolonged excess activity causes the disease, and beta blockers are used to treat these diseases, which are born out of this reaction. What are the actions of beta blockers? The beta blocking effects, if we look at the heart, it's a negative chronotropic effect at the SA node, negative dromotropic effect. It doesn't allow the conduction to go easily. Anti-arrhythmic effects, negative inotropic effects, anti-ischemic effects, something very good. And interacting drugs, nodal depression is by verapamil, diltiazem, digoxin, amiodarone. Be careful in combining with beta blockers. Other negative inotropes are also, you have to be careful with that. Now, what are the indications for beta blockers as on today? Angina pectoris, myocardial infarction, prime indications. Heart failure, prime indications. Atrial fibrillation, cardiac arrhythmias, symptomatic tachycardia. We quite often find it. And this is best treated with a beta blocker. Hypertension per se, mitral valve prolapse, Marfan syndrome, acute aortic dissection, hypertrophic obstructive cardiomyopathy. Say 30 years back, it was a contraindication. Now it is an indication. Other indications like pheochromocytomas in conjunction with alpha blockers, a rare disease, cyanotic spells in children. Glaucoma, migraine prophylaxis, again a very important indication. Essential tremors, prevention of variceal bleeding in portal hypertension, anxiety disorders, and probably some mitigation in hyperhidrosis. What are the controversies with beta blocker therapies? The role of beta blockers in the management of heart failure is very well established. There's a paradigm shift. What was once considered a contraindication has now become a class 1A indication. And the one person who worked against all odds to prove this point was Dr. Finn Vaxtein. Role of beta blockers in the management of hypertension is also very clear. Types of beta receptors we know. Beta 1 is located in the heart and kidneys, beta 2 located in the lungs, gastrointestinal tract, liver, uterus, vascular smooth muscles, skeletal muscles, and also present in the heart. These are the organs which all, they participate in this fight or flight reaction. And the beta 3 are located in the fat cells. They are present also in vascular smooth muscles and mediate the vasodilatation induced by nitric oxide in response to vasodilating beta blockers like nebivolol. Now, if we look at the organ effects of beta blocker, propranolol, nadolol, timolol, they are the so-called non-selective beta blockers. They act at both beta 1 and beta 2. And the selective beta 1 blockers, like bisoprolol, atenolol, and metoprolol, they act mainly at beta 1, very mild effects at the beta 2 receptors also. And this is where we want them to act. Beta 1, decrease heart rate, decrease contractility, decrease AV conduction, decrease renin release, something which protects the kidneys then, and decrease aqueous humor secretion in glaucoma. Now, what are the risk factors for heart failure and increased sympathetic overactivity is the basic thing. Effect of different adrenergic receptor activation in heart failure is like beta 1. Once they are activated, cyclic AMP mediated effects are there. Enhanced excitability and contractility will lead to tachycardia, tachyarrhythmia induction. Once there is a tachycardia, then a tachyarrhythmia can get induced. Myocardial hypertrophy will occur, remodeling, accelerated cellular death, renin-reduced stimulation. And we know that heart and kidney, they form a continuum. At the beta 2 adrenergic receptor level, cyclic AMP mediated effects are less intense, but then tachyarrhythmia induction, presynaptic norepinephrine release stimulation occurs. And at the alpha 1 receptor level, there is a vasoconstriction, tachyarrhythmia induction is at all 3 beta receptor levels. And myocardial hypertrophy and remodeling occurs in response to this. Sodium and water retention occurs at the beta 1. Beta 1 selectivity of various beta blockers is very different. If you look at the cardioselective beta blockers, and this is where we use them all, like metoprolol and bisoprolol, they are the ones which are useful in heart failure. Selective beta 1 blockade and reduced sympathetic activity we know in heart failure, and like carvedilol, which acts at all the 3 levels, beta 1, beta 2, and alpha 1, is quite often used. Metoprolol is again a drug of choice for beta 1 receptor blockade. Same is true with bisoprolol, nebivolol also. Now, we've been talking of beta blockers in heart failure, and let's look at the heart failure in India. You see the mean age in the Asian sudden cardiac death in heart failure, Asian heart failure registry. I was part of it, and the Trivandrum heart failure registry. They involved around 1,436 patients in the Asian heart failure registry, and in the Trivandrum heart failure registry, we had almost 1,200 patients. the mean age was 57 or 61, so an average will be 58, 59. 75% males, and common etiology was ischemic, DCM, RHD was also there in 8% of people, but mainly it was ischemic heart disease. And common comorbidities were CAD, hypertension, diabetes. So, and almost 15% had atrial flutter, 15.5% had COPD, and COPD is no contraindication to a selective beta blocker usage. So if we look at it, it's quite common in our country also. And if you look at various registries, almost the data is same type. So IHD, coronary artery disease, they form the bulk of the patients. And if we look at the meta-analysis of beta blockade, and we'll find that beta blockade improves survival in elderly heart failure patients. Everything favors beta blocker. All these trials, Copernicus, Carvedilol, US trials, CBIS True, Merit heart failure, Merit HF trial was the one which established and concretely put it on firm footing, the beta blockers in heart failure, and the best trial. Now, beta blockers, we know, reduce mortality in heart failure with reduced ejection fraction. And the relative risk reduction in mortality with ACE inhibitors is 17%, beta blockers 34%, aldosterone antagonists 30%. And now we have, ARNI, the sacubitril valsartan combination. But again, it is equal to beta blockers. And the latest kid on the block, the SGLT2 inhibitors, they also reduce mortality to the tune, relative risk reduction to the tune of almost 30%. Now, reduced mortality in heart failure with reduced ejection fraction with metoprolol Merit HF trial. And you see, this was heart failure patients with LVEF of less than 40%. And metoprolol reduced the mortality in patients with heart failure. Graphs, they start separating within 3 to 4 months itself. And they keep on separating. And this is with sustained release preparation of metoprolol. There is an improved survival with carvedilol also in patients with severe chronic heart failure. This was proved in Copernicus study. And again, you see the effects, they come pretty fast. Within 2 to 3 months, you see the separation of graphs. And cardiac, the CBIS2 trial was with bisoprolol, 34% reduction in all-cause mortality with bisoprolol, and 36% reduction in hospital admission for worsening heart failure. Well, we talked everything good about it. What are the contraindications to beta blockade? The compelling contraindication is asthma and any high-grade sinoatrial or atrioventricular block. And of course, bradycardia, if somebody already has a heart rate of less than 60 beats per minute, please be careful about it. Possible contraindications could be a metabolic syndrome, glucose intolerance, athletes, and physically active patients with less heartbeats. But glucose intolerance became a biggest stumbling block with atenolol, not with other beta blockers. So what are the guidelines saying? If you look at the ACC/AHA 2017 hypertension guidelines, beta blockers for heart failure with preserved ejection fraction, they are class 1, group 1 indication. If you look at 2018 ESC, ESH hypertension guidelines, therapeutic strategies in hypertension with heart failure, and look at it in patients with heart failure with reduced ejection fraction, it is recommended that BP lowering treatment comprises an ACE inhibitor, ARB, and a beta blocker and diuretic or a MRA if required. And this is class 1 level A. No controversies, my dear friend over here. It is to be used. ACC/AHA 2017 heart failure guidelines, beta blockers for heart failure with preserved ejection fraction. Well, recommendation is the use of beta blocking agents, ACE inhibitors, ARB in patients with hypertension is reasonable to control blood pressure in patients with heart failure with preserved ejection fraction. Of course, it is 2A and C. ESC 2060 in heart failure guidelines. Again, beta blocker is recommended in patients with asymptomatic LV systolic dysfunction and a history of myocardial infarction in order to prevent or delay the onset of heart failure or prolong life. It's a very strong statement, and it is class 1 level B. A beta blocker is recommended in addition to ACE inhibitor for patients with stable symptomatic heart failure with reduced ejection fraction to reduce the risk of hospitalization for heart failure and death. See the hard endpoint. And it is class 1 A, level A, 100%, no questions on this. In summary, my dear friends, heart failure is global burden with hypertension as the root cause. Beta blockers are important in treating heart failure and have proved useful in reducing the likelihood of progression through the continuum of heart failure. They should be included in the therapeutic regimens of patients with asymptomatic LVSD to prevent progression to symptomatic heart failure and to improve survival. Evidence-based beta blocker therapy of bisoprolol, carvedilol, or metoprolol succinate sustained release is a mainstay of treatment in all symptomatic patients with heart failure. Thank you, my dear friends. I hope I was much in time.
Yeah, thank you very much, sir, for a wonderful presentation. And now
Thank
I
you.
hand over session to Dr. Sanjay, who will be speaking on the topic common mistakes in the management of hypertension. Dr. Sanjay, over to you. Hello.
Hello, am I audible? Hello. Am I audible here?
Yeah, sir, you are audible, sir.
Okay, just a second, I will. So, thanks a lot for giving me this opportunity to talk this evening. After a scintillating presentation by Dr. Chauhan on beta blockers, there is a presentation. The topic today is common mistakes in management of hypertension, and we are going to talk about some common issues that that happen day to day life, and clinicians are measuring blood pressure, and what are the common problems and common mistakes that we people do in managing hypertension. Now, namely, if you look at the common mistakes in management of hypertension, they are either inappropriate measurement of blood pressure itself, or you have not done the diagnosis correctly. You have started a medication which is contraindicated in a particular disease, or you have given monotherapy to people who require combination therapy, and then the problem is lack of adherence, especially in elderly.
Excuse me, sir, your presentation is not there right now on the screen, sir.
It is not there. Just a second. Okay. So let me just go back to the Zoom and am I visible?
You are visible, sir. I'm able to see you, sir.
I will just share the screen, then only it will come.
Yes, sir. Yeah, now it is now presentation has come, sir. Yes.
Okay. So, as I said, the topic was common mistakes in management of hypertension, and I will try to be as short and as quick as possible. Pointing out that the common mistakes in management of hypertension may include inappropriate measurement of BP, incorrect diagnosis, medication is contraindicated in specific diseases but is still given monotherapy, or lack of adherence, especially in the elderly. Now, look at the inappropriate measurement of blood pressure. That is the first part. And how important is it? You can understand that overestimation of blood pressure by just 5 millimeter can lead to inappropriate treatment in approximately 30 million patients. So it will mean an unnecessary treatment and cause potential side effects of medications which people who are not requiring the drugs, and mislabeling as hypertensive with attendant psychological issues, though the person may not be hypertensive at all. Similarly, underestimation of blood pressure by 5 millimeter will mean mislabel approximately 20 million patients with pre-hypertension when they actually are true hypertensives. So what should be the ideal cuff size that have been taught to us right from the days of physiology, but nobody bothers? It is, should have bladder length, which is 80% of the width, that is at least 40% of arm circumference. You can see some of the newer cuffs nowadays have this marked out. And if you are the person arm is bigger than your cuff size, you will be automatically, while tying the cuff, know that the cuff size is inappropriate. And we should always use a simple way in the day-to-day clinic is to use 3 cuffs. One is for small arm people, the normal standard arm cuff, and then the large arm cuff. The large arm cuff is something which you can use even for a thigh, as a thigh cuff for small arm individuals. So the AHA also recommends the cuff size based on arm circumference. You should always have appropriately sized cuff in your clinic. And if the arm circumference is just, you can see, you can have a usual cuff size, which very commonly comes as small adult and large adult sizes, and then adult thigh cuff, which should be available in the clinic to measure the BP. Then one has to look at what is written as the poor sitting posture. Basically means that the person should be sitting with the feet flat on the ground, so should be supported. The arm should be supported, and if the person is hanging his arm down, the blood pressure will vary. Do not tie the cuff over clothing. You have to take off the shirt, or you roll up the shirt and then tie straight away on the skin. Then again, inappropriately sized cuff, person is talking or having full bladder. Also, you should add that the person must be not exercising before 30 minutes before you measure. So any person who comes to your clinic, before you measure blood pressure, one should know that the person has not smoked and not walked, did not do any exercise, or has taken any caffeine or any tea and coffee in preceding 30 minutes. Then you may have falsely high blood pressure. He should be sitting comfortably in the office for at least 5 minutes, resting, and then only you should start measuring the blood pressure. Now, incorrect diagnosis, as I say, brings more complications. Then what is the misdiagnosis? That you may delay treatment, you inappropriately follow-up plan was done, and the inappropriate follow-up means lack of follow-up, incorrect intervals, no documentation of follow-up. Complex slide, but basically this is slide which tries to tell you, to simplify things, that patient may have no hypertension and diagnosis of miss, as you can see on the top, or patients can have intervention in medications. This is a Korean nursing slide which basically tells you how one has to keep a regular follow-up of people, and do not do mistakes of diagnosing hypertension when it is not there, and not diagnosing hypertension when it is there. Now so what it basically means is errors of omission, and as well as inappropriate treatments, as I pointed out, treating people who do not require and not treating people who require hypertension. In current scenario, there are very important things of mask hypertension and white coat hypertension. So you know that the person is normotensive, no hypertension either in your office nor at his home. Sustained hypertension will be hypertension at home and hypertension in your office. Masked hypertension will be in your office, person does not show blood pressure, but he goes home, not because he interacts with his wife and gets hypertensive, because of various other reasons. He may be having obstructive sleep apnea, he may be having disturbed sleep in the night, causing evening or late night rises of blood pressure, or maybe having diurnal variation where BP tends to be higher at one particular time in the evening or early morning. And then white coat hypertension is when he has hypertension right there in your office, but when he goes home and relaxes, this we have been explained number of times, and then he does not have hypertension. So gradually people are realizing that you need to do more ABPMs maybe, or you need to do more home blood pressure monitoring to find out these two entities, masked hypertension and white coat hypertension. This is important. One is to detect these before you start treatment. So remember that you do not start treatment looking at the first blood pressure and jump onto the bandwagon of starting a treatment. You look at the blood pressure repeatedly, and then only you start the hypertension treatment. Now, then medications may be contraindicated in certain group. We look at this group of drugs which should not be given, or there are compelling indications. So there may be, you sure somebody has contraindication. For example, somebody has gout, or you do not use diuretics. Somebody is having hyperkalemia, you don't use an anti-aldosterone drug. Or renal failure, you avoid because you'll get into hyperkalemia. Beta blockers, just now Dr. Chauhan told you in so many things, but remember, they can get troubled in asthma, they can precipitate COPDs, bronchospasm COPDs. They are contraindicated in grade 2-3 AV blocks. And also, probably as a diabetologist, I can tell you that people who are in pre-diabetics, a combination of beta blocker and diuretics especially, both have tendencies to convert a pre-diabetic into diabetic. So new onset diabetes is commoner, though not taken a very significant thing, but it is important entity. Person who's hovering on the borderlines of pre-diabetes, and you load them with beta blockers and diuretics, in long run may precipitate diabetes. So you have to look after that aspect also. Similarly, people who are on ACE inhibitors, can have hyperkalemia, and they are contraindicated, both ACE and ARBs, in bilateral aortic stenosis, as well as people who may have urticarias, or people may have history of angina aortic edema. You should be careful. Alpha blockers are notorious for orthostatic hypertension. So they are the various contraindications which one should see when you start a particular drug. And a common mistake is not realizing that these problems are there and starting a particular drug. Now, again, as this is similar, I just pointed out ACE inhibitors and thiazide, and this I've already pointed out. Now, then mistake of starting monotherapy, person of combination therapy, I don't think this should be listed like this, but one has to understand that majority of people who are hypertensive will ultimately require some degree of combination therapy. So in today's current scenario, I think logically anybody whom you are treating with monotherapy is the one who has BP less than 150/90, and a slot between 140 to 150 systolic you are starting, you can start with monotherapy. Any further, anything above 160, 180, 170, 180, probably combination therapy is good enough. And it's a controversial question whether you should keep on escalating the dose of a single drug or you should use a combination. Most of the guidelines and most of the, if you look at major trials where placebos were compared to, the intervention arm, you will see that intervention arm always had some sort of combination or the other. And it is an accepted norm there that a combination therapy is better than monotherapy at any point of time. And as I pointed out, more than 75% of hypertensives will not be controlled by BP with monotherapy, and you will require some sort of combination therapy. Also remember that some of the combinations will help you to cut down the side effects. For example, if you use maybe an ARB with a calcium channel blocker, for example, using amlodipine with the CCB, amlodipine like CCB with the beta blocker, maybe you can control the reflex tachycardia, or you use it with a diuretic, you can control edema. ARB in combination with the CCB like amlodipine will have less edema. So various side effects can be looked after. For example, using a diuretic with the only combination that I would not recommend is ARB and ACE combination, which are a strict no, which number of studies have shown you do not use an ACE and ARB together. All other ways, the commonest combination currently used is CCB ARB combination, which is a very useful combination, not only with regards to blood pressure therapy, but also to reduce the overall side effects of both the drugs. Now, in non-adherence, again, it's a big problem. So you have logically only 1 in 7 people with raised blood pressure have it adequately controlled. And again, they are not taking the prescribed medications because, so therein goes the idea of taking 2 or 3 drugs in so-called single pill combination, the SPC combinations. You use more and more drugs in a single pill so that the person can take. Also understand in elderly, they have decline in cognitive function, decline in physical well-being, multiple comorbidities, and they have complex treatment, so they may not be adherent to their treatment. And it's a silent killer. So you will have number of those HMODs, the multiple organ dysfunctions because of hypertension that can happen without any, clear clinical signs and symptoms. Remember that more than 1 billion people are living with high blood pressure, and by 2025, more 1.5 billion people will have hypertension. And if we continue to not treat them adequately, we will continue to have more and more complications. Thank you.
Thank you very much once again, Dr. Sanjay, for such a wonderful talk and adding your clinical expertise, sir. And now I invite Dr. Saket to further take the session and the next topic, that is diagnosis and management of hypertension in young hypertension.
All right, my screen is visible.
Yes, it is visible, sir. It is visible.
All right, thank you very much for the introduction and the opportunity to give a talk on the diagnosis and treatment in young hypertensives. They behave somewhat differently, and you'll have to look for other causes of secondary hypertension in someone who is young. So we all know this. It is the leading risk factor for death and disability globally. 1.5 billion will have hypertension. If you look at mortality worldwide, it goes beyond 58% for hypertension. Cholesterol, ischemic heart disease follows. And 1 in 5 in young adults in India has high blood pressure. So that is equal to 80 million people, more than the entire UK population. This is from the Great India BP survey, 24 states. 1,80,000 adults and 18 to 39 years, they found that the prevalence of hypertension was 19%, and 15% are on treatment, 49% had uncontrolled blood pressure. Risk factors in young, like adults, the emerging risk factors are sedentary lifestyle, especially in the COVID-19 era, wherein people are working from home, diabetes, obesity. Obesity is also on the rise now, or high salt diet, junk food, illicit drugs, psychiatric conditions of the youth. It can be both primary essential hypertension or secondary hypertension. The important part is in young hypertensive, you have to rule out secondary causes of hypertension. Etiologies, most common would be renovascular in a lot of young hypertensive, especially in females. It can be fibromuscular dysplasia of the renal arteries. So it can be renal mesenchymal disease, as also renal vascular disease. Get a urine examination, renal ultrasound biopsy if needed. For vascular disease, get a renal ultrasound, renal angiography, CT and MRI can be done. A lot of endocrine causes can cause hypertension in young. That can be both thyrotoxicosis as also hypothyroidism. Thyrotoxicosis leads to isolated systolic hypertension, whereas hypothyroidism leads to reversible diastolic hypertension. Hypercortisolism, wherein you'll have to go in for overnight DEXA suppression test or a low dose DEXA suppression test. Overnight DEXA suppression test is a simple test, can be done in the outpatient setting, as also LDDST, that is a low dose DEXA suppression test, can be done in outpatient setting. LDDST is somewhat more cumbersome. ONDST is very comfortable for the patient also, but the sensitivity of LDDST is way higher than ONDST. So many people have got rid of ONDST and they go in for directly LDDST. Pheochromocytoma, where there will be increased secretion of catecholamines, so you can basically screen by 24-hour urinary free catecholamines, metanephrines, and BMA. For if you have a very high index of suspicion, you'll have to go in for 24 hours catecholamines and fractionated metanephrines in the serum. MIBG scan would be diagnostic if you're looking for a pheochromocytoma, and anatomical localization can be done by MIBG scan. Primary hyperaldosteronism is suspicion would be high if you have hypokalemia. It is important that you correct hypokalemia before you go in for a plasma aldosterone by renin ratio. And the confirmatory test is after intravenous saline or oral saline loading test. You can go in for unsuppressible plasma aldosterone. And then if you have a diagnosis, a biochemical diagnosis of primary hyperaldosteronism, that is followed by imaging. Never image the patient first. It is a golden rule of endocrinology also, that first of all, get a biochemical diagnosis, then go in for your imaging. Don't go in for imaging first before you get a biochemical diagnosis, and you will get stuck because a lot of endocrine organs do have incidental masses. Hyperthyroidism, hyperparathyroidism, serum calcium, phosphorus, ALP, serum parathyroid hormone, and albumin, so that you can get corrected calcium, as also 24-hour urinary calcium, phosphorus, and creatinine will have to be done. Acromegaly, if you have a clinical suspicion based on the clinical signs, you can get the IGF-1 levels done first, that are the screening tests. If they're found to be high, you'll have to do a growth GH suppression test. Isolated growth hormone or baseline growth hormone levels can also help, but it is always wiser when you're suspecting that the growth hormone level would be high. It is always wiser to have a suppression of growth hormone levels by glucose load and look at the growth hormone levels. After you have the results of IGF-1, basal growth hormone, and suppressed growth hormone, you can either go in for MRI. That would be better for acromegaly, because the most common cause of acromegaly, as we all know, is a pituitary macroadenoma. Coarctation of aorta is the vascular cause for which echocardiogram, Doppler CT imaging can be done. OSA, a very common cause, frequently missed in obese diabetics. You have to go in for a polysomnography for hypertension. Same implications as in adults. Young also, they'll have left ventricular increased thickness, left ventricular mass will increase, left ventricular hypertrophy, Hemodynamic would be higher mean pulse pressure, higher stroke volume, higher total resistance index. And the incidence of CV events would start increasing very rapidly in hypertension in the young also. It evolves over a lot of years. Small and large arteries of the heart may be involved. Some changes may be very early and often go undetected for a lot of years. There are changes in the vasculature, there are changes in the cardiac muscle also. So that can basically lead to damage to the large arteries that can further widen the pulse pressure and will promote further damage. And this will increase left ventricular wall stress and promote left ventricular hypertrophy and dysfunction also. Usually, the change in large arteries basically goes undetected in clinical practice unless clinical signs of ischemic heart disease, stroke, or renal disease or PVD develop. Invariably too late to reverse the structural damage, and treatment serves only to delay the further insidious decline in end organ function. This basically, you can see pre-hypertension to established hypertension can affect the kidneys, the heart, the brain. You can have proteinuria and atherosclerosis because of renal involvement. You can have LVH, you can have retinopathy as Bisphanger lesions, and the symptomatic lesions. If it gets symptomatic, you can have CRF, ESRD, you can have CAD, systolic diastolic dysfunction, atrial fibrillation, ventricular arrhythmias, dementia, TIAs, and polysymptomatic or end-stage disease would be ESRD, MI, CHF, ventricular tachycardia, fibrillations, and stroke, and all this can culminate into death. So if there is increased stroke volume and aortic stiffness, that contributes to isolated systolic hypertension in young adults. As you can see, the quartiles change, and that also increases the stroke volume and aortic stiffness. Sympathetic tone also has a role to play. It is basically imbalance between the sympathetic tone and the parasympathetic tone. So either an increase in sympathetic or a decrease in parasympathetic tone would increase the numerator. If the numerator is increased and the denominator decreases, that can also lead to a host of dysfunctions like metabolic insulin resistance, dyslipidemia, metabolic downregulation, trophic increase in catecholamines, elevated renin-angiotensin levels, insulin levels would increase, higher shear stress and increased pressure, elevated heart rate, vasoconstriction, rarefaction, low plasma volume, high hematocrit, co-coagulation, platelet activation. All this would lead in diabetes, vessel hypertrophy, LVH, arrhythmias, and may result in thrombosis also. So a lot of things can happen because of a disbalance between the sympathetic and the parasympathetic tone also. We'll take you quickly through diagnostic evaluation. Initial evaluation, confirm the diagnosis of hypertension, assess cardiovascular risk and organ damage, and look at the concomitant clinical conditions that the patient has. As already discussed by the previous two speakers, accurate blood pressure measurement in both upper limbs may be required in lower limbs also if you're suspecting coarctation of aorta. A retinal examination to look at hypertensive changes, look for abdominal or peripheral bruits, look for renal bruit and look for other bruits also. Look at hemoglobin levels, complete urine examination, look at the thyroid profile, and that means not only a TSH, look at the whole thyroid profile, a T3, T4, TSH, look at renal function tests, serum electrolytes, especially potassium, look at the electrocardiogram, whether it has evidence of LVH or evidence of hypokalemia or not, and go in for a 2D echocardiogram. The water investigations would depend on what you're suspecting: hemoglobin, hematocrit, fasting plasma glucose. I'm not very fond of only getting a fasting plasma glucose if you have a suspicion of diabetes mellitus, because in the natural history of type 2 diabetes, we all know the postprandial glucose rises first, or the post-glucose load glucose will rise first. So whenever you have a suspicion of type 2 diabetes, always wiser to get a oral glucose tolerance test, not only rely on the fasting plasma glucose, and do get a HbA1c. Although we know that HbA1c has a lot of fallacies. If the hemoglobin is low, you can have a false high HbA1c, but keep in mind those things. So always get a OGTT done if you have a suspicion. Look at the cholesterol profile, look at the serum triglycerides, sodium, potassium are very important. Look at uric acid. High uric acid is a marker for metabolic syndrome also. Have a look at creatinine and estimate the eGFR. Look at urine analysis and get a 12-lead ECG. A specific test, if you are suspecting, if you have a renal bruit or otherwise also you have hypertension in the young, going for a renal sonography. If you find that the kidneys on one side is smaller, going for angiography of the going for a CT MRI, and then if there is a need, you can go in for angiography. So CT angiography also. Cushing disease, I already was talking, get a ONDST or a LDDST. That basically means overnight DEXA suppression test, that is with 1 milligram dexamethasone and taking cortisol values. Dexamethasone is taken at 11 p.m. and you do a cortisol on the next day at 9 a.m. Whereas a low dose DEXA suppression test is basically more sensitive. That would entail taking 0.5 milligram of dexamethasone. That would be 6 hourly for 8 doses, and then you'll go in for a cortisol level. Get a complete thyroid profile to look for both thyrotoxicosis and hypothyroidism if you have a clinical suspicion. Look for plasma renin aldosterone for suspected hyperaldosteronism. Look for that is basically the BAC-PRA ratio. And you have to be careful. You have to prepare the patient well before you plan screening. There are certain drugs that you don't have to give. I guess discussion of that is outside the scope of our presentation today. Pheochromocytoma, get a 24-hour urinary catecholamines. You can also guess if the index of suspicion is very high. You can go in for 24 hours metanephrine, 24-hour catecholamines, and fractionated metanephrines. Otherwise, if you are having a suspicion, 24-hour urinary catecholamines would do good enough. Acromegaly, if you have a suspicion, it is serum IGF-1. That is the screening test. Then you can go in for a basal growth hormone if the IGF-1 is high, and do go in for a GS suppression test after a glucose load if the clinical suspicion is very high. Look for amphetamines and cocaine, urinary screening. That is not very common in our country, but now after some of the cases that we saw on television also in Mumbai, probably it is more common than we know. Serum markers, GGT, oxidative stress, CRP, marker of inflammation. How do you manage these patients? Young hypertensive, if you manage hypertension really well, there is a 29% reduction in major adverse cardiovascular events, 33% reduction in CV mortality, and a 37% reduction in heart failure also. The goal blood pressure, 140/90. If the patient does not have comorbid conditions, CKD, proteinuria, you'll have to get the blood pressure down to 130/80. It is preferred. ADA recommends lower targets, less than 130/80 for young patients with hypertension and diabetes. The blood pressure thresholds for and goals of pharmacological therapy in patients with hypertension, according to the clinical condition, you can see journal is clinical CVD or 10-year ASCVD risk of more than equal to 10%. The blood pressure threshold more than equal to 130/80, you have to start treatment and get it down to 130/80. No clinical CVD and 10-year ASCVD risk of less than 10%. The threshold for starting treatment would be more than equal to 140/90, get down to 130/80. And otherwise, if you have diabetes mellitus, CKD, chronic kidney disease after renal transplantation, heart failure, stable ischemic heart disease, secondary stroke prevention, lacunar strokes, PAD, the threshold is 130/80 and get down below 130/80. But if you are preventing, you want secondary stroke prevention, the threshold for starting treatment would be more than equal to 140/90. But the goals are almost equal for all the conditions, that is less than 130/80. Lifestyle changes play a very important role in all these disorders. Weight reduction, maintain an ideal BMI of below 23. That would decrease the systolic blood pressure by 5 to 20 mmHg per 10 kg weight loss. A DASH eating program, rich in fruits, vegetables, low-fat dairy products, reduced content of saturated total fat, would decrease the blood pressure by 8 to 14 millimeter. Sodium restriction, less than 2,300 grams of sodium, or that would decrease it by around 2 to 8 mmHg. Physical activity, 30 minutes most days. Brisk walking would decrease by 4 to 9 millimeter. Moderate alcohol, men less than equal to 60 ml per day twice a week. Females less than equal to 30 ml per day twice a week. If you can abstain, that is the best. That can decrease blood pressure by 2 to 4 millimeter mercury. Tobacco, that has to be total abstinence. Coming to pharmacological therapies, the ABCD algorithm, pharmacological management. Younger subject, less than 55 years, step 1 is if associated with sympathetic hyperactivity, it's basically a inhibitor ARB or a beta blocker. If is an older adult, more than 55, it is either a ACE inhibitor plus minus calcium channel blocker. If the step 2 is if you have a younger subject, you can add calcium channel blockers and diuretics. And step 3 can be whatever is left out, you can add. For older subjects, you can add a diuretic as the second line therapy, third line therapy, and whichever is left can be step 3 for our patients. If you look at ARBs and cardiovascular risk reduction, there is a stroke reduction by 9%, heart failure reduction by 10%, major adverse cardiovascular events, the composite of stroke, CHD, heart failure, reduction by 9%. So to prevent 9 strokes, 7 heart failures, 20 major adverse cardiovascular events, every 1,000 patients have to be treated for hypertension for 5 years. ACE inhibitor ARB in comorbid conditions, preferred therapy in patients with diabetes and hypertension. They have to have it because of the multiple benefits that they offer for patients with diabetes and hypertension. Beta blockers, if they are very anxious, young hypertensives, ischemic heart disease, stable unstable angina, post-MI patient, heart failure, patients who are intolerant to ACE inhibitor ARBs, or women of childbearing potential, they may be given beta blockers. Metoprolol, cardioselective beta blockers may be preferred over the non-selective ones. Reduction of cardiovascular mortality with beta blockers, you can see all the trials, they favor beta blockers versus placebo. So you can have a decrease in CV mortality with these drugs. ACC AHA guidelines for hypertension, beta blockers in heart failure, you can see they are right there with ACE inhibitor ARBs for compelling indications like previous MI and stable angina as a first-line therapy. Diuretics reduce CV events with diuretics. They are also a very good class of drugs, chlorthalidone or hydrochlorothiazide. Hydrochlorothiazide can basically cause some degree of increased glucose levels also, so you have to be careful with that also. If you have comorbid conditions, what do you do for hypertension? If you have diabetes, for example, initial choice would be an ACE inhibitor ARB. The second preference would be a CCB, and the third would be thiazide diuretics. CKD, again, ACE inhibitor ARB would be the first one. The second preference would be CCB and thiazide diuretics, and other drugs can be taken as a third preference. CAD, beta blockers, ACE inhibitor ARBs, first preference, CCB, thiazide diuretics are the second preference. For stroke, again, ACE inhibitor ARBs. So you can do most of the conditions like diabetes, CKD, stroke, ACE inhibitor ARBs, even CAD, they're right up there. Even in heart failure, they're right up there. And the other drugs, they basically are the second preference for the treatment of hypertension. Combination therapy according to age, we already have discussed this slide, I guess. And if you have a patient who is on 3 or 4 drugs uncontrolled, you'll have to look for causes of resistant hypertension also. This algorithm already probably has been discussed. Lifestyle modification plays a very important role, and then you go in for pharmacotherapies. Younger, you'll have pre-hypertensives, you basically have to target because they have vasoconstriction, increased peripheral vascular resistance, that's remodeling. RAS system is activated, as also sympathetic nervous system is activated. You'll have to target those things at that time. So in summary, hypertension in the young is increasing in prevalence. Evaluation of secondary causes of hypertension has to be done. A thorough history and clinical examination is vital. Assessment of renal parenchymal vascular disease should be individualized, and lifestyle therapy remains the cornerstone in the management of hypertension. In the young, a goal of 140/90 is recommended for hypertension without comorbid conditions. Lower goals 130/80 for hypertension with comorbid conditions, ACE inhibitor ARBs. Most of the conditions, they're first-line agents, and CCB, thiazides, beta blockers are, depending on the comorbid condition that you have, can be added, or if ACE inhibitor ARBs are not tolerated. Thank you very much for the patient hearing. Probably we'll take all the questions now after that.
Thank you, Dr. Saket, for such a wonderful and detailed presentation on the management and diagnosis of hypertension. Now, sir, there are a few questions which has came from the audience side. I'll be asking those questions one by one. For the first question for Dr. Chauhan is that which beta blocker has the least side effect and which is the first choice in the treatment of hypertension? Dr. Chauhan.
Yes, the cardioselective beta blockers are the ones to be used. Metoprolol, bisoprolol, carvedilol are the choices. If you ask me, I use metoprolol sustained release preparations as my first choice.
Right. So the second question is for Dr. Sanjay. In what situation the screening for secondary causes of hypertension is necessary?
That point already Dr. Saket Khan pointed out. There are certain clinical situations, younger hypertensives, one should be careful. People who come to you with accelerated hypertension, it is you have to remember the secondary causes of hypertension. Maybe there are patients who are having difficulty in controlling, you should be bothered that it is not a simple case of hypertension. There can always be symptoms which will, telltale signs of hypothyroidism clinical examination. You find people who are having sweating, palpitation, episodic tremors, you may start suspecting pheochromocytoma. So unexplained weight gain, patient or cushingoid appearance. So it's a mixture of looking at the clinical symptoms as well as clinical signs, and have a high index of suspicion. In your day-to-day practice, the people who are coming to with accelerated hypertension, resistant hypertension, new onset hypertension, younger hypertension, these are the subset of patients where you start looking at more carefully at the patient.
Thank you, sir. Thank you. So next question for Dr. Saket. Sir, if a patient is having hypertension in his family, so what he should do to prevent it, or how the doctor can convey the same to a patient, the same thing?
I was already explaining the risk factors for hypertension, and you could see obesity, sedentary lifestyle, high salt intake, and these are basically the important things. If the patient has essential hypertension, that can be exacerbated by if the patient is obese, has a sedentary lifestyle, does not exercise at all, has a high salt intake, has diabetes mellitus or hyperlipidemia, that can increase the risk of having hypertension. So the secondary causes of hypertension are not preventable, but lifestyle modification would help a lot if the patient has a family history of hypertension.
Thank you, Dr. Saket. And the next question is for Dr. Chauhan. So the question is that ramipril safety in primary or newly hypertensive patients.
Well, what about it?
The question came like that: the safety can be used as a first line of therapy for the treatment of hypertension, primary hypertension?
By all means, yes. Just look at the potassium levels, check it every week, and the patient should not be having, renal artery, especially bilateral renal artery stenosis. These are the two absolute contraindications to starting a, ACE inhibitor.
Thank you, sir. Thank you. And our next question is for Dr. Sanjay. The question is said that generally the thought is that men is at higher risk as for hypertension or high blood pressure as compared to a woman. So what are the myths and what are the facts?
You can also see in general, the prevalence of hypertension seems to be higher in men compared to women. But if you look at the the sex ratios between the two, postmenopausal women are almost identically prevalence of hypertension compared to men. And the CVD risk factors also, remember that the people who are women tend to fare actually worse when they have hypertension and CVD compared to men once they come up with that. So it is a common myth that the women are well protected and they will not have a higher risk mortality because of CVD. But when you look at the both the subgroups of postmenopausal women as well as the women who are established CVD, they tend to do actually worse compared to men.
Thank you, sir. Thank you.
Though remember that the incidence of both hypertension as well as the prevalence of hypertension and CVD is higher in men compared to women.
Thank you, sir. Now the last question that I'm going to take is for Dr. Saket. The question is that which is the best therapy for the treatment of hypertension, diabetic hypertensive? What is the drug of choice?
Well, the drug of choice is indeed an ACE inhibitor or an ARB. There was some controversy regarding ACE inhibitors being better for patients with type 2 diabetes and ARBs being better for patients with type 1 diabetes, but I guess it does not make a difference. Whether you use ACE inhibitors, ARBs, does not make a difference. Both are equally good in patients with type 2 diabetes, but somewhat ACE inhibitors may be somewhat better for patients who've got chronic heart failure with preserved ejection fraction or even reduced ejection fraction with type 2 diabetes. Otherwise, does not make a difference. You can use the maximum tolerated dose of ACE inhibitor ARBs and then go in for the therapies. They do really well in patients with type 2 diabetes and hypertension.
Thank you, sir. Thank you. So there are other questions also, but due to pause of time, I'll be taking these questions only. And remaining of the question, I'll be personally sending it to you and we'll give the answer to the audience later, sir. So I take this opportunity to thank each and every one of you, sir, for taking the time out, Dr. Sanjay, Dr. Saket, and Dr. Chauhan, and making this event successful. And thanks to the audience for taking time out and be participative. We have more than 30 audience logged in right now, as per the number which I have seen, sir. And thank you very much, the support team which has made this program successful. We are optimistic that we will be doing this kind of program in the future also to upgrade and update the management of different kind of diseases. Thank you very much, sir. Over to you all.
All right. Thank you. Bye-bye.
Thank you, sir. Thank you. Danish, we can close the meet. Thank you.
Sir, shall I stop live streaming?
Yeah, you do that.
Okay, sir.
Okay, thank you.